Yeah, I think they gave me such a juicy title, so the flight was worth it. But I think my most important disclosure, while these show, is actually that I did a year dedicated for high-risk PCI and CTO training, so clearly my perspective is also skewed that way. And while I'm supposed to spend the next 8 minutes going over some issues that we review in the guidelines with respect to CTO specifically, you've already seen this image, but I think there are a few things that are really important takeaways in terms of shared decision-making. I think this comes up all the time, and some of the work they've done around LAAO occlusion and some of the patient shared decision-making factors in there, I think we could do a better job of applying to CTO PCI specifically, but certainly this is important. And actually the guidelines pointed out that while we really emphasize mortality and durability and all these other important things from trials when we're making our heart team discussion recommendations, patients may have different priorities. And actually in this one survey from 2013 at least, even when death was presented as higher with PCI, patients still preferred that over CABG. So I think there's a lot to unpack there on an individual level, but we need to get down to that to help make the best decision for the patient. Now, what's the deal specifically with CTOs? Altogether, while we've already reviewed that there was a Class 1 indication for treating symptoms with PCI when patients have refractory angina on medical therapy, we in the guidelines actually noted that despite suitable anatomy with refractory angina on medical therapy after treatment of non-CTO lesions, the benefit of CTO to improve symptoms, CTO intervention to improve symptoms is uncertain. And I think what that really comes down to is that guidelines are based on randomized trial data. And we have, an embarrassment of riches in cardiology. A lot of our recommendations are based on this. But if we're thinking about high-risk patients in particular who are receiving an intervention, I think running good trials like this is hard. And we see that in the trials we have. So if we drill it down to a very simple example, if you offer my dog the ability to enroll in a trial where he gets the kibble that he gets every day and is already taking versus that, plus this really gross looking bone that's available on Amazon, he's not going to enroll in that trial. He would just order that gross bone on Amazon. Unfortunately, he's very dumb and he can't do that. But I think with our patients, by the time they get referred to a specialty center, they've already maximized their medical therapy. Most of them have voted with their feet and are highly motivated. So I think generalizing that to the broader population we actually see in clinic is difficult and is also limited by variable success rates and other things. So I think overall part of the issue is that guidelines really emphasize randomized trials, but real-world data is really relevant in this patient population. So if we look at the two main trials that they quoted, Decision CTO had a really difficult time enrolling and went over 7 years, and they still had slow enrollment, but did manage to get over 800 patients in. But there are a number of factors there. So actually 14% of the patients did not have any anginal symptoms. They were randomized before they underwent non-CTO PCI, so a number of patients actually had improvement in symptoms related to treatment of other lesions. And the crossover was 18%, but actually that happened almost right away within 3 days. And so obviously a lot of the patients were actually just dissatisfied with their randomization, not that they came back months later with a small STEMI or something else that led to intervention. So because of all these reasons, from a post hoc analysis, that was deemed to be underpowered. But the guidelines really emphasize this because it is the largest randomized trial to date that we have for CTO patients undergoing a randomization for intervention. If we look at EuroCTO, that also dealt with slow enrollment, and they only got to about a third of the patients they had planned. They underwent 2-to-1 randomization, which probably did help with crossover, which was about 7%. And so if we look at the results that we get from there, I think there's some things that are not too surprising. One, in Decision CTO in that selected population, we didn't see a change in MACE rates or symptoms that was statistically significant, but both groups showed improvement in quality of life scores. Remember, they also had other lesions treated before they were selected for this. If we look at EuroCTO, what we do find is that the patients who were in the PCI arm, a much smaller proportion of them end up with class 3 or very low rates of class 4 angina in follow-up after intervention compared to the control arm. And I think that's why when we're counseling patients, this is what we're really focusing on. Interestingly, in that group, they did see a lower rate of MACE with the p-value of 0.02 when they're looking at 3 years. And so I think when we look at all of this data across the board, the trials are great to give us some ideas, but they're highly selected patients. And so one really helpful registry was the Open CTO registry because this was 1,000 consecutive patients. These were at high volume centers with a high skill set. They were complicated. Procedural success rate was actually a little bit lower because this was core lab adjudicated, but despite that, patients did show an improvement in symptoms that was quite significant. I think that also gave us some really important data to help us counsel patients about clinical perforation rate and things like that because it was core lab adjudicated and really well done that way. And not surprisingly, the patients who had the highest burden of angina are the ones that we saw the highest benefit from in terms of their Seattle Angina Questionnaire. And importantly, these patients were, nearly all of them were appropriate or maybe appropriate by appropriate use criteria. And these patients were on good medical therapy and all the important things coming in. I think the other challenge that we deal with is that we're defining what's generally a physiologic problem in terms of ischemia by anatomy alone and drilling it down to something as simple as CTOs. When we're often having these heart team discussions of multivessel CAD patients, oftentimes part of that factor is because they have a chronic occlusion. And so we're trying to factor that into a more complex thing. In addition, I think Dr. Wexman mentioned this earlier, not all CTOs are created equal. So this gentleman, unfortunately, his lima went down a month or two after surgery, had recurrent symptoms. They have a patent being grafted to a diag here, so the anatomy was pretty complicated on the diagnostic, but we can see with the dual angiogram that actually connects better than we would have thought. I crossed that with a workhorse wire. This is a case from Tuesday. And in general, now this gentleman's LAD is taken care of, and hopefully his symptoms will get better too. So I think altogether, we're making these anatomical distinctions, but is that in part because of our risk tolerance for the procedures? They are higher risk than general PCI, technical limitations, or both. And I think if we look at some comparators like vein graft PCI, which is also high risk for acute and downstream complications, that in general we're recommending the native artery if that's feasible, and CTOs are a big part of this patient population presenting for intervention, as well as redo CABG with a patent lima is higher risk. And so I think a lot of the patients we're seeing actually fit these descriptions better, and so I don't know that there's as little certainty in those groups. Altogether, I think in part there is a high rate, a big part of this is our skill set, and so trying to continue to get better at our skills and our center experience really does seem to matter. If we look at the Michigan data, using insurance data, the high volume centers treated patients with higher baseline risk. They actually had the same rate of MACE events after the procedures with a higher success rate. And so I think taken a different way, low volume centers still had an increased rate of complications, but without that achievable success rate. So I think altogether, using different techniques and having the skill set to work on that can hopefully make these cases safer. So I think where do we go from here? Well, certainly emphasizing shared decision making is really important because there's lots of areas of uncertainty there's no right answer in many of these cases. I think once we make the decision to do PCI, whether it's CTO or not, we want to perform that in a way that is more consistent with Syntax 2 than Syntax 1. So the guidelines mention that the stents have improved, but there's a number of other things they did there. One of those was increase their CTO success rate, but the patients were on high rates of goal-directed medical therapy, and they used much higher rates of imaging and invasive physiology. So altogether, I think as long as we continue to get better, then we can probably study this better in terms of the data. So just to end on that, I think there's a number of courses, these two sponsored by CRF, including CTO Summit, have really been helpful for me in terms of my pattern in addition to this course. Epic Live, which my counterpart is a part of, was also great for kind of learning different things, getting out of our own lab and learning new tools. And just a plug for the Woman is One Climb program has a CTO dedicated group, which is a really fantastic way to build your skill set. Thank you.